Well, welcome. And this is a whirlwind course in many regards, even though it's 4 days long. But the good news is there's a lot of redundancy. So you will learn, I think, the very most important things. And I think by hearing the things that are repeated, you'll get the sense of what is truly, the most important. So speaking of redundancy, I'm probably going to maybe disappoint Doctors Lang or Gemma, but in contemplating this talk, I decided that I would avoid the right ventricle. We have a limited amount of time right now. Dr. Rudsky will be speaking to you and gives probably one of the clearest talks on the right ventricle that I've ever heard. And so I, in that way, am humbled, and I don't want to lead you down any garden paths that Dr. Rudsky, who is really, sort of the king of the RV, would be. So I decided that I'm going to focus on the left ventricle and the left atrium. And I think, although there will be many take-home messages, my biggest message is, please don't panic. This is a very fair exam. If you know the basics and you are familiar with it from this course, you'll do just fine. So, sit back, relax, take a deep breath, and listen, and you'll take home an awful lot of useful information that will help you pass. In terms of the basic assessment of the left ventricle, we can think of it in three ways. First of all, we have to assess ventricular chamber size using either chamber dimensions or chamber volume. We want to assess ventricular muscular mass. That can be done in various ways. We can speak of the ventricular wall thickness, which we do a lot in the clinical laboratory because it's quick and easy to measure. We can talk more formally about what elevated wall thickness or increases in left ventricular mass really mean when we talk about myocardial hypertrophy or overall myocardial mass. And we also, in that combination, need to be able to speak not only of elevations or changes in left ventricular myocardial mass, but also changes in left ventricular geometry. And so we have to talk a little bit about that today as well. A basic assessment of the LV also requires us to assess systolic and diastolic function. And you're going to be hearing a lot about assessment not only of systolic function but also of diastolic function using various techniques in echocardiography over the course of the next 4 days. In terms of measuring chamber dimensions, there are basically two ways. I have some gray hair, but mostly no hair. But when I came as a young whippersnapper into the Echo Lab at Penn to train in 1992, we were still doing M-mode measurements predominantly to do chamber size, and we had these big sheets of thermal paper. Luckily, the thermal paper is gone, and I do think that some people wish that M-mode was gone as well. But M-mode is actually very helpful. It has great resolution and great time-space resolution. So we still make M-mode measurements, at least in many labs, including my own. So you need to be aware of M-mode. These days, M-mode is guided with 2D imaging. I think Dr. Patil has already showed you a little bit about that. I'll re-emphasize it. And when measuring in the M-mode, we use what is known as a leading edge to leading edge convention, which means you start the septum at the leading bright edge on the side of the RV, and you stop at the endocardium, the bright leading edge of the endocardium on the LV side. So too with the LV cavity, you start at the leading edge of the bright endocardium at the septum, and then you go down to the leading edge, which is the bright endocardial border in the inferolateral or posterior wall, We'll see this in a picture shortly. Two-dimensional imaging is clearly what we do most of in modern times. And the good things about two-dimensional imaging is that when we do measurements, either online or post hoc, we're able to much better orient our measuring calipers in a perpendicular orientation to the chamber itself, which is really important because we want to be able to have reproducible measurements, comparable measurements over time. We want them to be measured orthogonally or perpendicularly to the main axis of the left ventricle. We don't want oblique measurements because your degree of obliquity may vary from study to study. And so to have any sort of comparability or reproducibility, we need to sort of be very cognizant of being perpendicular to the long axis of whatever structure we're measuring, in this case, the ventricle. Two-dimensional measurements do require a good endocardial definition. If you have a technically very limited parasternal long axis view, you can be led astray. So best not to measure it if there's any questions about where the endocardial borders are. In terms of measuring, the latest guidelines from the ASE strongly recommend opting for two-dimensional imaging. So most of the measurements that you'll be seeing on the exam will be given to you. I have not come across any instances where you actually are taking out calipers or trying to measure it yourself. They are usually given to you, but that you may need to be aware of whether or not they're on axis or are being done appropriately. Here is actually something taken from a very old textbook of echocardiography from a respected author about standard M-mode assessment. And we can see here in the pictures the septum and the posterior wall are measured using the leading edge to leading edge convention. Left ventricular end systolic dimension in M mode is measured at the furthest incursion of the septum, which tends to precede the furthest incursion of the infraposterior wall. So you measure, however, at the deepest incursion of the echo, and that's end systole. And end diastole is typically measured at the onset of the QRS complex. And again, in a leading edge to leading edge assessment. We can see here, I don't know if it's too small from even my point in the room to really look at it, but if you look, this has been done in a 2D guided method. But if you look at the sort of the upward tilted LV, our M-mode cursor only can sort of move in a certain pie-shaped arrangement, and you'll notice that this measurement is actually being made slightly off axis. So this is actually an oblique M mode. So even though it was and this is a textbook from many, many years ago, probably just as 2D was coming out, I did find it rather telling that even this illustration shows some of the problems with M mode measuring, because if you're not completely on axis, you're going to be oblique, and you really have to pay attention to that. In terms of M mode, normal M mode measurements, the interventricular septal diameter should be less than 1.1 centimeters. LV internal diameter during diastole less than 5.6 centimeters. Posterior wall thickness similar to interventricular septal thickness, less than 1.1 centimeters, and obviously LV internal diameter during systole is highly variable. Oh, push the wrong way. 2D measurements, again, the preferred way to go. It should be measured in freeze frame. This too leads to a little bit of controversy. Even if you read Dr. Lang's excellent guideline document from 2015, and perhaps he'll share with you his preferred method, but I know I've looked through it carefully because Dr. Susan Wiggers, former president of the ASE, and who's been a mentor of mine but now is a colleague, we argue about this continually, about when to measure things. And so I went back because she said to me, well, I'm going by what the guidelines say, not by, your whim. And I went back and I carefully read the guidelines, and there are actually both things are mentioned. So end diastole can be measured either as the first frame after mitral valve closure, which is the Wiggers method, at least in my lab. Or for me, it's the frame in which LV diameter is the largest. My argument there being that if the mitral valve is closing, the left ventricle must be contracting. So, why wouldn't you go for the largest diameter? I'm not sure why this... There, back. Sorry about that. So either of those is acceptable. There may be slight differences between them, but they are both listed in the guidelines. End systole can be the first frame after aortic valve closure, or the frame in which LV dimension is the smallest. Once again, I would like to emphasize that these all should be ideally made in the parasternal long axis view. There are many labs, including when I inherited the lab at Temple, that make these in the parasternal short axis view, with the assumption that, well, if it's close to looking like a donut, we must be on axis. The truth of the matter is it's very hard to tell whether you have subtle elliptical sort of deformation or whether you're truly have the perfect perpendicular donut in the short axis. So truly these measurements should be made in the parasternal long axis view. And here are some examples of appropriately made measurements. The measurements should be made somewhere approximately mid-chordal level. They should be below the leaflet tips of the mitral valve, but certainly not as deep as the papillary muscles. I find that we run into some difficulty when you have a sigmoid septum, sort of a twisted septum where the septum bends down and in. Sometimes the rest of the chamber looks rather large, but if the technologist or the physician measures too close to the mitral valve, you get that sort of falsely shortened sort of internal diameter closer to the base, where the sigmoid septum is actually bending in. So I tend to be a little bit more liberal with my more chordal level of mid-chordal level of measurements when I have a patient with a sigmoid type septum, otherwise known as disproportionate upper septal thickening by some. If you look closely, since this was done by me, I'm using the largest frame and the smallest, the largest diameter that I could visually find, and the smallest diameter that I could visually find, which is usually about a frame before closure or of the aortic, or a frame before closure of the mitral. So what are the normal measurements? I can see the panic spreading throughout the room. You'll hear about these more and again. And the long and the short of it is these are all available in the guidelines. Most of us have them tacked up on a bulletin board somewhere in our echo labs. But, don't panic about the exam. These are gender specific norms in terms of cavity size. I would just focus on, personally, on what is the range of normal, so that you know what's abnormal. Because especially, there's no way, at least there's no way that I would be able to memorize all of these, including the indexed diameters. We tend in the echo lab, or at least most of the echo labs that I've talked with, we tend to speak in terms of just the diameters. Ideally, we should probably not only be speaking in terms of gender-specific diameters, but also body surface area index diameters. But I don't think you need to really focus on memorizing all of this, for the exam. I do put it in here for reference purposes, and Dr. Lang, I'm sure, will cover it in his next talk. So with these dimensions, these basically single plane dimensions, what can we do? Well, we can't do much with them other than say, well, it looks like the LV is dilated, or it looks like the LV is normal sized. What we used to do back in the days of M mode was to sort of do a single dimensional ejection fraction, which is called fractional shortening. It is rather archaic. I don't know that it will appear as a quintessentially important part of a question on an exam, on the ASCE exam, but it does rear its ugly head. It shows up on virtually many echo reports and on virtually every echo machine, and a question or a case might throw out there that the fractional shortening was less than 25%, or the fractional shortening was 10%. So I think it's worthy to know that in the back of your head, and basically it's a single dimensional ejection fraction. It's the internal diameter during diastole minus the internal diameter in systole over the internal diameter during diastole multiplied by 100, and normal is greater than 25%. It is inherently limited because, of course, we're using a singular dimension to try and assess a three-dimensional structure, and it's very much inaccurate in the presence of regional wall motion abnormalities, especially those in the more mid to apical areas of the ventricle, because they'll be missed. The fractional shortening at the base may be very well normal, but the apex may be, very severely depressed. So I do mention it because I do see it come up from time to time. I doubt that it would be the primary portion of a question. Volumetric measurements of the left ventricle are a more accurate assessment of LV size. We can furthermore use the volumes end diastole and end systole to calculate an ejection fraction. Most of our techniques that we use today are two-dimensional techniques based on geometric assumptions. Simple assumptions are usually easier to use but less accurate. More complex assumptions are more accurate but sometimes less easy to use. But this has become less of a problem in today's very digital world, because some of the more complicated assumptions can now be done on the fly while you're doing the echo, and it actually has become quite easy to use. So volume assessment in the left ventricle has definitely come a long way since 1992 in my introduction to echo. We can use 3D techniques. I'll show you an example of that in a minute or two. They are very accurate when compared to cardiac MRI and other techniques. They are still relatively infrequently used in regular clinical practice. There aren't too many guidelines with regard to LV volumes by 3D quantitation techniques, so I would not expect that you would see anything about that on the exam. 2D techniques, as I said, make assumptions. The simple ones make more assumptions than the more complicated ones. And I won't go into great detail about the problem with making an assumption. You all know what the major problem there is. But in echo, the assumptions on both 2D and M-mode based models, it assumes a symmetrical LV. The rotational ellipse and the prolate ellipse models tend to neglect focal abnormalities. They're based on a single measurement at the mid or mid to basal cavity. And the more complex models may be more accurate, but still have underlying symmetrical symmetry assumptions. Here's the rotational ellipse. Probably one of the oldest sort of ways that LV cavity volume was assessed. It's typically assessed this way using M-mode measurements. And basically, it calculates a volume of a rotational ellipse where the diameter B and the diameter D are the same length, and A is considered to be about 2 times that of D. And so when you plug all of those into a volumetric equation, the volume can be simplified down to being approximately equal to D cubed. So we can measure the diameter and we can cube it on the M mode in the parasternal long axis, and voila, you have an approximate volume. It is the simplest geometric approximation. It should be used with M mode only, and it is certainly not accurate in cases of abnormal LV shape, but you have to realize that many of our large-scale epidemiologic studies, for instance, the Framingham study, etc., have relied upon this technique for years. They have switched over gradually over time, and more modern studies probably don't use this, but the D cubed formula has a place in echo epidemiologic literature, and you may come across it on an examination. Left ventricular cavity volume can also be assessed using 2D measurements in the area length approximation. Here we measure the endocardial area of the LV cavity in the parasternal short axis view at approximately mid-chordal level. And then we measure the length of the cavity in the one of the apical views, most probably the apical 4-chamber or the apical 2-chamber view. And 5/6 times the area times the length gives us an approximation of LV volume. Probably what you're most commonly familiar with and what you'll see most commonly on the ASE exam is Simpson's method of discs. This does have some assumptions of symmetry, but because you're dealing with multiple discs, it eliminates most geometric assumptions, and when done in a biplane fashion, can calculate the volume of an asymmetric ventricle quite clearly. The ejection fraction is easily calculated from this. In the old days, this was torture to do because you had to digitize taped images and make these measurements. Now, of course, our technologists are making Simpson's method of discs measurements on a daily basis, on your inpatients and your outpatients. The thoughts behind the Simpson's method is that it's a summation of discs. What the measurement does is it subdivides the left ventricle into a series of discs of a finite height and a measurable radius. And disc volume of each individual disc is calculated as pi r squared times h. And the sum of these various disc volumes is added up to give you overall LV volume. Biplane is best. You should always attempt to do biplane measurements with Simpson's method of discs using a combination of the apical 4-chamber and the apical 2-chamber view. Notice that in this example from the apical 4-chamber, we trace the endocardial border as best we can. And along those lines, we include the papillary muscles as part of the ventricular chamber. We don't, we trace underneath the papillary muscles. And we also include any major or large trabeculations within the chamber. It's counted as part of the chamber volume. So you're really trying to make a smooth trace of what would be the non-trabeculated endocardial border. So these are things that you need to be aware of when you're assessing a Simpson's volume that is presented to you, as well as the ejection fraction derived from that. Reference ranges for the volumes, including volumes indexed to body surface area, are presented here. Again, note, I think the most important thing of note to make mention of is that there are male and female gender-specific guidelines and cut points. Once again, I would probably, for the purposes of this exam, really just focus on the diastolic volume and focus on what is the upper limits of normal for the diastolic volume of both the male and the female gender-specific criteria. LV ejection fraction can obviously be calculated easily from LV volumes. N systolic volume is subtracted from N diastolic volume and divided by N diastolic volume multiplied by 100% to give you a percent EF. The guidelines for mild, moderate, and severely depressed LV systolic function or LV ejection fraction are presented here. You will notice that the really major differences in terms of gender are found in the normal range and the mildly abnormal ranges. The moderately and the severely abnormal ranges are comparable between the two genders. I would obviously know what mild, moderate, and severely depressed ejection fraction are. So take-home point, this is something to probably commit to the memory. Here's an example from our institution of a 3D volume and ejection fraction calculated from 3D volumes. Various machines do it in different ways, but basically you're asked to pick out various points on the parts of the myocardium. The machine makes an auto trace in the three views as noted here. You can usually edit those endocardial decisions based on the automation to fix things up a little bit, and then a 3D volume is generated. Both N diastolic and systolic volumes can be determined, and ejection fraction as well. So again, it can be done. There are no specific guidelines for specific 3D determined volumes, and outside of knowing that you can use 3D techniques to assess LV volumes and function, I wouldn't expect that you're going to required to know a lot of cut points or guidelines for those volumes or criteria. Dr. Patil has already touched on this, and so this is just a quick review. Regional wall motion is typically in most labs discussed on a 17-segment model, which is the model that I'm circling on the right side of this slide. It is important to commit to memory the various orientation of the various segments, both the basal segments, the middle segments, and the apical segments, including that 17th or apical cap, and what their logistical names are based on the ASA criteria. So you'll hear this is just something you need to commit to memory. It's not really that hard. And you'll hear more about this in terms of when people discuss ischemic heart disease, when we're referring to various wall motion abnormalities and their locations. I'd like to move on now to left ventricular mass, going beyond taking volume one step further. Why is LV mass important? Well, LV mass, when it's elevated, is an issue of left ventricular hypertrophy. It is a pathological adaptive process that we see not only in ischemic heart disease, but also in valvular heart disease, congestive heart failure, etc. So it really is important to understand left ventricular hypertrophy and its corollary or intimately related to it, left ventricular geometry. So bear with me. Left ventricular hypertrophy is considered abnormal increase in LV mass. It's an important prognostic indicator. The basic concept is that the LV mass is just an expression of the mass of the cardiac muscle. So in terms of calculating that, basically what we're trying to do with echo is determine what is the volume of myocardial mass. And then we can multiply that by the specific gravity of muscle. Well, the volume of myocardial mass is nothing more than the internal volume of the ventricle, the endocardial volume of the ventricle that we've just been calculating and talking about, subtracted from the epicardial volume of the ventricle. So all of our calculations for LV mass are basically a subtraction of the volume of the epicardial myocardium minus the internal left ventricular or endocardial, the left ventricular volume, multiplied by the specific gravity of muscle, and that gives you the muscle mass. Typically, these are done using the rotational ellipse model, and that would be LVIDD cubed as the endocardial volume. And the epicardial volume is then simply the LVID plus the interventricular septal thickness plus the posterior wall thickness, that entire thing cubed, one subtracted from the other and then multiplied by specific gravity of muscle. Same using the area length. Use area length to estimate an epicardial volume. Subtract from that the endocardial volume, multiply by the specific gravity of muscle, and you have muscle mass. Simpson's method of discs is not typically used for mass assessment, and that's because it's very, if you've ever tried, trust me, I've tried it, if you've ever tried to trace the entire epicardial surface of the heart on an apical view, it's near next to impossible. So Simpson's method of disc is not typically used. LV hypertrophy is an adaptive response. We've already mentioned that. You see it in a number of pathologic situations, and it's very important that we should be able to tell our colleagues in heart failure, our colleagues in the valvular heart disease department, etc., how severe is the LVH, and as we'll see in a minute, what kind of LV hypertrophy is it, to really help to care for our patients. And you will be expected to know these differences on the exam. So in terms of mass-based LVH criteria, we tend to talk about indexed LV masses only. This is something where indexing has really taken a grip. So you need to know these mass-based LVH criteria. And for male or female, there are gender-specific cut points of what counts as abnormal elevation in mass. It also depends on whether it's M mode or 2D derived. What you'll see mostly on exams and in papers, etc., is greater than 115 grams per meter squared for men, greater than 95 grams per meter squared for women. But don't be surprised if in a 2D situation they're mentioning another cut point. But I would commit these to memory so that you take that into account. In the clinical echo lab, we tend to, at least I've been having our techs measure LV mass a little bit more commonly to help me tell my colleagues the true hypertrophy. But many clinical echo labs will just go on wall thickness alone as sort of a poor man's estimate of LV hypertrophy. And based on the guidelines, these are the 2D wall thickness criteria for the presence and severity of LV hypertrophy. And you probably will want to put these to memory as well, because you might come across a question based on wall thickness only. But this misses a lot in terms of the pathophysiology. So I just briefly want to touch upon LV geometry, which is what the pattern of hypertrophy basically. Hypertrophy is minimization of wall stress. The stress and myocardial oxygen consumption of the myocardial wall are directly related to the pressure in the chamber and the radius of the chamber. It is indirectly related to the thickness of the wall of the chamber. So the thickness of the wall spreads out the force that the wall needs to maintain due to the pressure and volume stressors that the ventricle is associated with. With hypertrophy, wall thickness is increased in both pressure or volume overload. However, cavity pressure is the main driving force in pressure load, and cavity radius is the main driver of hypertrophy in volume loads. And they create a different appearance to the ventricle. And the way we express this in echo is something called relative wall thickness. Here's a short axis view of a cartoon LV cavity. And relative wall thickness, RWT, is classically defined as 2 times the posterior wall thickness divided by the left ventricular internal diameter, and is typically approximately 0.33, 0.34. It's a dimensionless ratio. Now you will find there's a gradual shift. Some people are arguing that it should be, rather than 2 times the posterior wall thickness, it should be the interventricular septum plus the posterior wall thickness. That is likely a very appropriate way of doing it, and the ratio should still be approximately the same. I do caution you, though, in cases of disproportionate upper septal thickening or asymmetric septal hypertrophy, that very, very, very thick septum may not really give you an overall sort of idea when added to the posterior wall thickness. It may lead to overestimation of the relative wall thickness, but you will see that we are shifting slowly to sort of IVS plus posterior wall thickness divided by left ventricular internal diameter. Why is this darn stupid ratio of importance? Well, it basically defines concentric or pressure overload hypertrophy, where the thickness of the walls in relation to the diameter of the cavity is greater than 0.42, meaning you have basically a normal cavity size. This is emphasized here when it looks smaller, with very thick walls, versus eccentric or volume overload hypertrophy, where the cavity is very dilated. So even though the walls are thicker, the cavity is dilated and the relative wall thickness stays the same. So relative wall thickness defines pressure versus volume overload hypertrophy. We'll go through these relatively quickly in the interest of time. They're in your notes. Pressure overload hypertrophy or concentric hypertrophy is typically characterized by an increase in systolic pressure without major changes in cavity radius. By this Laplace relationship of wall stress, the increases in pressure are balanced out by an increase in wall thickness. Increases in left ventricular wall thickness leads to increase in left ventricular mass to above normal range, but also accompanied is an increase in wall thickness, an increase in LV mass, and an increase in relative wall thickness, because the radius of the cavity is not changing. The thickness of the walls is increasing because of increased pressure. Here's an example of a pressure overload hypertroph. The left ventricular internal diameter here is normal. Posterior wall thickness is 1.5. It's quite thick. And the relative wall thickness is 0.62. This is a hypertrophic ventricle. It has abnormally increased mass, but it has elevated relative wall thickness. Volume overload hypertrophy is typically associated with an increase in diastolic chamber size, an increase in the radius of the chamber with very minimal changes in pressure. Here, radius increases, the thickness of the walls increase because to equalize and normalize wall stress. But because you have a commensurate increase in the diameter or the radius of the cavity with the wall thickness, you get an increase in wall thickness with an increase in LV mass, but no change in relative wall thickness. And this is an example of a more volume overloaded, or otherwise known as eccentric hypertrophy ventricle. The left ventricular internal diameter is dilated. It's 7.0 centimeters. The posterior wall is thick. It's 1.2 centimeters. The relative wall thickness, though, is 0.34. So this is a volume overload hypertrophy. This has shown up on both my certification exam and my recertification exam. This description of LV geometry based on normal versus abnormal mass and normal versus abnormal relative wall thickness. You'll have the normal geometry here where the wall thickness is below 0.42 and the mass is normal. You have people who have normal mass but elevated relative wall thickness. This leads to something called concentric remodeling, sort of a pre-hypertrophy state. And then in terms of the hypertrophs, where mass is elevated, you have concentric hypertrophy with elevated relative wall thickness and eccentric hypertrophy with normal relative wall thickness. So that is something that you should keep in mind. And as I mentioned, these cut points for LV mass, the gender-specific cut points of 95 and 115 are reasonable to memorize. Although normal relative wall thickness is 0.33, the abnormal cut point is greater than 0.42. Briefly, the left atrium. You don't need to know this, but I included this just to sort of show you. It's a good study aid to sort of think of the various phases of the mitral valve flow as well as the pulmonary venous flow. The left atrium has basically three functions. It's a reservoir. During systole, it collects the pulmonary venous return. It is a conduit in early diastole, and it is a contractile chamber in late diastole during atrial kick, where 20 to 25% additional volume is pushed into the left ventricle. Presence and degree of left atrial enlargement is significant. It is a prognostic in many disease states, as shown here. You will see that dilated left atrium, in terms of left atrial volume, is one of the criteria you're going to use to determine diastolic levels of diastolic function. So knowing how to quantify the left atrial volume is important. In the old days, parasternal long axis views were used to just measure an AP dimension, and while this is tried and true and still measured in many labs, it is often non-representative of true LA size. And so, like the LA is best characterized by a biplane left atrial volume using apical 4-chamber and apical 2-chamber measurements. They're more meaningful than left atrial areas. And while single plane volumes are okay to use if you have a very technically limited study, a biplane is preferred. And we do index to body surface area. This is an example of a biplane measurement. Remember to exclude the pulmonary veins. Do not start tracing upward into the pulmonary veins. They are not part of the left atrium. And you will see this, I'm sure, once again, but indexed LA volume is very important to know, particularly greater than 34 milliliters per meter squared. It is a bit of a moving target, but for diastolic purposes and other purposes, I would certainly commit at least the 34 milliliter per meter squared cut point to mind. LA volume can be done in 3D, but then again, this is an unproven and relatively unused technology. And so with that being said, and in the interest of time, I thank you for your attention, and we'll move on.